So today, Carly and Rebecca from North Dakota Brain Injury Network are going to talk about the screening and symptom inventory. So they're going to get into a little bit more of that. It goes until 1 o'clock, so I want to make sure we have plenty of time. And the link this time, it is working. There was a technical glitch on the technical IT part last time, so I apologize for that. But it is working because I checked. So at the end, I'll place in the chat a survey for you guys to click on and answer questions, and then it will prompt you further to answer additional information so that you can get a CEU or a certificate of attendance for today. If you have any questions, feel free to reach out to me. My name's Kelly Larson. I work with the Behavioral Health Division with the Community Connect program. So welcome everyone. Feel free to enjoy your lunch because this is lunch hour. Ask questions in the chat. I'll monitor that. You can stay on camera, off camera, whatever you feel most comfortable with. So I will, for time, I will let you start it off, Carly, and welcome again. Thank you.
Thank you. Thank you so
You're
much for
welcome.
having us. We're excited to be here. This is our kind of our title slide, if you will, but all of our names are listed there so you can see who is a part of the Brain Injury Network. Rebecca Quinn is our director. Myself, I'm a senior project coordinator, and then Nikki and Shannon are both resource facilitators. Rebecca and I are housed in Grand Forks, and Nikki and Shannon both work remote. So Shannon lives in West Fargo and Nikki lives in Towner. But we do serve the whole entire state. So don't ever let where we live impact you reaching out for help, because we are happy to come out and help you where you are too, or virtually of some sort. But yeah, we're going to talk about screening and symptoms for brain injury today. And we hope you consider maybe implementing screening with your clients or with your agency as a whole. But let's just talk about why you should screen. So the first thing so everyone's on the same page. I know we talked about this last week as well, but just want to make sure to reiterate the fact that acquired brain injuries are any damage to the brain occurring after birth and prior to degenerative dementia. So again, like Alzheimer's, we would probably refer you to the Alzheimer's Association. Something like fetal alcohol syndrome, we would probably reach out to Dr. Larry Bird with the Fetal Alcohol Syndrome Clinic and get services that way. So it's not that we would be like, nope, can't help you. But if we're looking at really technically what's a brain injury, those two do not fall into that category. But then there are two kind of categories under the umbrella term of acquired brain injury. And one is a TBI, which most people are familiar with. So that's any injury from external force. So something outside of the body coming into contact with the body. So motor vehicle crashes, domestic violence, assault, falls, injury blasts for veterans, those kinds of things. And then there's a whole other side of the spectrum where there are acquired brain injuries, but they're non-traumatic in nature. So things like oxygen deprivation, and we can get oxygen deprivation many ways, near drownings, failed suicide attempts if like hanging was the choice. The drug overdoses, so anyone needing to be like Narcan or naloxone would be an example of oxygen deprivation. Infectious diseases, so things like meningitis, encephalitis, long COVID, all those are brain injuries. Chemical or substance exposure. So this can even be like lead poisoning, but this can also be even like alcohol. Like we have a lot of individuals that abuse alcohol and then end up with long-term consequences like dementia related from that. And then strokes or tumors would be also considered brain injuries. So leading causes of TBI now, falls are the number one. And if you remember from last week, I shared that falls are consistent here in North Dakota, as this slide is for, nationwide, but we are on track with that as well, as falls being our number one reason for referral. And specifically, they are falls from the ice in the winter time. So, slipping and falling on the ice. Sorry, did someone have a question? Just came in.
Yeah, Kaya asked if it included brain aneurysms. I would
Yes,
assume, yeah.
yes, yeah. An aneurysm, yes, is definitely a brain injury. Yes, good question. And there is a severity continuum, which we also discussed last week, just kind of doing some review for you guys, but this is also being looked at. So this might change a little bit here soon because it is very subjective and it's very hard, but mild by far is the highest category that we see. But that basically means the person was unconscious. So LOC stands for loss of consciousness for less than 30 minutes. A moderate injury is 30 minutes to 24 hours, and then a severe injury would be like a coma or longer than 24 hours. But the longer you are knocked out for, the more likely you are to have long-term impairments. But the tricky part about this is that many people sustain multiple mild injuries, and those have a compounding effect to be more like a severe injury. And then not everybody loses consciousness, and particularly children don't. Their adrenaline kicks in and has a lot less body to pump through than an adult's. So they are more likely to stay alert and not lose consciousness. So they often get missed. So there's just some issues with this severity continuum, but we haven't been given formal guidance yet. But once we do get formal guidance, we'll probably have to change a couple of things of what we do and how we assess. But basically, that loss of consciousness is important to consider. So we really don't want you guys that are working with clients to be like leery of brain injury, I guess, is what the point of this slide is we don't want you to treat it as separate and silo it out and like, oh, they have a brain injury. Oh, we'll send them on to the brain injury network. Because number one, we don't provide direct services. So you can send them to us for resources and support and referrals, but we're not necessarily going to be the one that meets with them regularly and kind of does like case management type role. But we will support you and the client as with their goals and with the brain injury in mind. But we really want to demystify brain injury, and we're not gonna, test you on the different loads of the brain. And we are all aware of that at the Brain Injury Network, the different loads, but that's just because of what we do day to day. But it's really not that important that you know every single lobe. And last week we talked about kind of the frontal lobe and the temporal lobe are responsible for our executive functions and a lot of our like behavior management type areas. And so those two are the really important ones to know about. But again, it really does not have to be this elaborate thing where you know all about the brain. But having the appropriate brain injury diagnosis really empowers people and to get the right services as well. Some people will give you pushback. I'll be honest. I see that all the time when we do brain injury screenings. People will say, like, well, what is that? What's one more thing? What's one more label? I already have, they already have alphabet soup behind their name with all their letters and stuff, right? And really, this one more thing really does tie everything all together. It connects a lot of dots, and a lot of the accommodations you can utilize for a brain injury are very, very easy to implement. There's not a lot of background work, or anything that goes into them. They're often things we can take away right away. So, when we look at the impact of brain injury, there's a lot of common cognitive impairments. So things like concentration, attention, memory, judgment, and the ability to follow instructions can be impacted by a brain injury. And then those can lead to poor outcomes with social interaction, problem solving, skill acquisition, occupational performance, and independent living. So these are why oftentimes probably a lot of your clients are needing your services is probably related to their cognitive impairments from their brain injury, but they might not even know that they have a brain injury, or they might not identify as having had a brain injury, or even realize that things that happened when they were younger could be a contributing factor to their behavior today. Yeah, so I think a lot of this would make up a lot of your clientele. I think probably struggle with this. When I was just doing the intro and cognitive in the last couple hours with Good Road Recovery, we talked about attention, and attention is huge after brain injury. Attention's like the first thing that kind of goes away, if you will. Their attention gets lowered. So almost to like a lot of our clients could possibly carry like an ADHD label, attention deficit hyperactivity disorder label. And so thinking about attention and those skills that work, or those strategies that work good for individuals with ADHD, a lot of those are going to work really well for your clients with a brain injury as well. So when we don't diagnose brain injuries, it can exacerbate health and social inequities, and it just makes it a lot more difficult to engage in services. So I know last week towards the end, I talked about scheduling consistent times to meet with people. And that's one example of when we don't do that, it makes it more difficult to engage in services. So with someone with brain injury, their memory is very, very glitchy. And oftentimes it's their short-term memory that's glitchy. And that's really hard for people to understand, because I think they think they're being kind of like played, or like, they're, how come you can tell me stuff you did when you were a little kid, but you can't tell me things you did yesterday? Like, it just, people don't quite understand that it's that piece, it's that short-term memory versus long-term memory. So after brain injury, that short-term gets impacted. And so if we set appointments for a different time and a different day of the week every week, and we don't have any consistency, that makes it more difficult to engage in services. So like an example of an accommodation we would suggest would be meeting at the same day of the week at the same time with clients. So just yesterday, I was at the Downtown Engagement Center in Fargo, and several of those clients are utilizing, several people that are staying at the deck participate in our lunch and learn program, and I'll explain that in a little bit. But a lot of them utilize either through recovery or community connect. And so I will ask them, like, when do you meet with your person? And I was so happy yesterday to hear one said Thursdays at 2, so he knew exactly when he was supposed to be there and what time. And if you have inconsistencies, if you meet, sometimes you meet Thursdays at 2 and sometimes you meet Fridays at 9, and all these different times, it can be really confusing for them to remember. So having simple things like consistency and routine can go a long way. But you can see that list there, that a lot of our individuals struggle with following through, making the actual phone call, setting up the appointment. They might need hand holding. They're probably going to need hand holding for that part of it. Oftentimes they don't remember program rules. They often don't remember difficulty with following rules and procedures. I think a lot of times that's because the rules and procedures are a little too complex, or written at a high level, that they're, want to bring that reading level down to probably about a 5th, 6th grade reading level if we can, when we're writing out different rules and procedures, and explain them at a level that they understand. And when we are explaining rules and procedures, we should be asking like our WH questions after, like, what did we just talk about? Why, when, where, how, all those things. And then just navigating this resource system. And that's been a huge learning curve, I think, even for me, coming from, I taught special education and I knew the education system side of things really well. And now I rely really heavily on Nikki and Rebecca to help me figure out this resource system for adults. And in North Dakota, and there's all these different, plans, and Medicaid and Medicare and all that, 1959 and Community Connect, and who qualifies for what. It's just a very complex process. And even like, I've helped clients apply for SNAP and those different kinds of benefits. All that stuff is actually very complicated, and really someone with the cognitive deficits that a brain injury entails is going to need support kind of navigating all of that stuff. So as far as where to start with a client, we want to start with the immediate need, right? So what is, and I personally always look at like housing as an immediate need, right? If you are unhoused, that is an immediate need, and we want to get you into housing. But who is there to access those needs and to support those? So that's when I ask, do you have a care coordinator you're working with? Are you on a list for housing? Anything like that. But we also have our symptom inventory, which looks at more the internal cognitive symptoms that will help them identify what they see as the most problematic. And it is very interesting. We will have clients. We were just on a call the other day with a woman in Colorado, and she was talking about this client of hers that was just basically like, like a shit show, to be honest. And all these things were going on in his life. But his biggest concern was his cat. Like, he didn't care about any of the other stuff, but he cared about his cat. So, and making sure that the cat was going to be, I think he was sentenced to like a prison sentence. And where was the cat going to go? And that was what was really on his mind. So it might not always be the same thing, but we want to look at what does the client identify as important and as most problematic, and try to work through that. While the whole time we're doing all that, though, we are going to build that therapeutic alliance and rapport, right? I think a lot of our clients feel like they're judged. And so giving like wait time and just slowing things down and giving them time to think, and not judging the choices that they've made, or maybe how they ended up with the injury themselves, or, like some of our domestic violence, I think they think like, why didn't you leave? That they think that's what we're thinking, but we have to just keep in mind that, like, that social worker hat, right? And that people are often making the choices with the best things that they have at hand at that time. So brain injury screening is something we are really trying to promote at the Brain Injury Network, because basically we have learned from other states and just nationwide groups we collaborate with that brain injuries hide in plain sight. We cannot see them. And they hide a lot amongst special populations. We call them our high risk populations. So general population is 12%. The homeless, about 50% identify as having had a TBI. Behavioral health is about 60%. So that's mental health and substance abuse are encompassed in that one. Criminal justice involved, this slide says 60, but we have seen as high as 87%, depending on the study that you look at, as those involved in the justice system. And then IPV would be referring to interpersonal violence. So about 75% of those that have had that in their history probably have a brain injury as well that they're dealing with. So these should send off red flags to you that, okay, if this person is currently homeless or experienced homelessness at one point, they might have a brain injury. Let's screen them. So screening is really a simple way to lead to awareness for the individual. So we're not trying to scare people or trying to add one more label to them, but I really just think it helps them to have that awareness piece. Self-advocacy. So a lot of the accommodations that we recommend are very simple and things that if they just speak up and ask, they can be given. So I even think of when we go to the Downtown Engagement Center and we do lunch and learn, I leave the lights off in the room because they are overhead fluorescent lighting and it's just kind of not as comfortable. And so now I'll tell clients at that meeting, the next time you go to meet with your care coordinator and you're in a room with fluorescent lights and it bothers you, ask them to turn the lights down. I mean, that's self-advocacy right there. That's all we have to do. We just have to do it in a respectful, kind way, right? And explain it too. I always coach clients on that. Like, because I have a brain injury, I'm sensitive to lights. Do you mind if we turn the lights off? Or because I have a brain injury, I tend to like to have fidgets, and so I like to play with things. There was a gentleman yesterday at the deck that had like a toy gun kind of thing. It was like a model of like a sniper gun, and he likes to just kind of like take it apart and put it back together. And I said to him, coached him through, like, you should probably explain this though. When you show up with this little mini model of a gun, that might kind of deter some people or scare people, and just say that, hey, this is my fidget though, and not that I have this like obsession with guns, or that I'm going to come in here with guns blazing someday. So I said, just explain it. So I think that goes a long way too, that advocacy piece. More effective treatment. I know I referred to last week, and I don't know if he's on this week, but Kelvin disclosed himself, so I'll disclose it too. But when Kelvin was first had his fall, Kelvin Samick, he fell at work and went into the ER and was sent home, and woke up a couple days later still not feeling well and having a lot more problems than he did when he left the hospital. So he went in again, and then I think they diagnosed, I can't remember what they initially diagnosed, but they referred him to an OT or a PT for vestibular therapy, which does work sometimes after brain injury, but it depends. And there's a lot of factors. But I think he went through like 37 PT sessions before the PT's like, okay, this isn't what's going on with you. This is more than that. So why waste all that time and all those sessions when we can, if we know from the beginning it's brain injury, we can get the most effective treatment. And there's a lot of new treatments options out there. There's even since I started at the Brain Injury Network, there have been several new things that have come about, even like the hyperbaric oxygen chambers. A lot of people are utilizing that and having good outcomes from that. A lot of people, there's a Cereset, it's like a sleep treatment. Lots of things that we can recommend, and we at the Brain Injury Network have pretty good relationships across the state with professionals that do all these different therapies. So even like speech pathology. So speech language pathologists can do a world of wonders for someone with a brain injury. But the tricky part is we have to find the ones that know how to treat brain injury. And that's what we know at the Brain Injury Network is we are aware of those professionals that are trained in brain injury and can work with you on your goals as far as brain injury, where some speech pathologists are working on like articulation and pronunciation of words and things like that. But there are speech language pathologists, so they work on the language piece, and they will teach how to implement structure, how to use a planner, how to allocate your energy resources correctly throughout the day, and things like that. So a lot of our clients are surprised when we say, hey, you should go see a speech pathologist. They'll be like, well, I talk fine. But it's not about how you talk, it's about how you process language. And so that's really our role, and we can help get that all set up. But it's really just important to know about brain injury so that we get the appropriate things in place. And then finally, screening is really easy to implement. I probably screen every day or so certain people, and it's maybe 5 to 10 minutes at the most to do. Oops, I'm sorry. Jumping around. Okay, so some people will say, and we've run into this problem even at the Downtown Engagement Center, where, like, why can't we just ask people on intake, have you ever had a brain injury? The research shows that that's not enough to get an accurate response. Number one, people don't talk like that. So majority of people will not say, I have a brain injury. They might say, though, I was knocked out, or I got my bell rung, or I saw stars, or I had an overdose, or I grew up with abusive parents, but they won't actually probably say, I have brain injury. So we can't just ask that one simple question. And that's even like when we were talking last week, Kelly, about, for Community Connect application does ask that. And I worry that we're missing people by just asking that way, but that is a start. We're getting there. So if you do see someone checked yes on that app, please refer them to us and we will work through that. But yeah, it just doesn't work. And the DEC tried this model too. So they've been asking people at intake, do you have a brain injury? And not many are saying yes, but when we come for lunch and learn, there's a significant amount of people. Like yesterday, I think we had 9 in group. And when we went around the room, I think every single one had a history of brain injury once we showed them the screener and asked the questions specifically. So the researchers that had developed the screener we chose to use, they designed it to ask this individuals questions to recall information they might have forgotten or things. And it shocks me every time when I go through this screener. There's usually a few that will, oh yeah, well, I had that one and then that one, and they have multiple that they, it just really, it has to be asked specifically to get them to trigger those memories. So NDBIN, when we were selecting a screener, we looked at several. I think we looked at like 3 or 4, but we selected the modified OSU TBI ID. There is also a long version. So OSU stands for Ohio State University, and then TBI identification. And actually ours is, I think that might be a typo, ours is the ABTBI identification, but it's a very basic tool, excuse me, but it's not diagnostic. So that's something we do have to explain to people. Like, we're not diagnosing you with a brain injury, but we're telling you you might have a brain injury. And so that's a whole nother thing, is to get them formally diagnosed. But we like to tell them that it suggests the presence of a brain injury. So this is the first step in identifying it. And then we can decide, okay, do we want to pursue a formal diagnosis or, you know, further evaluations and things like that, and our referral to NDPIN. But this is just a first step. So whenever we are implementing a screener with clients, we want to approach them with this trauma-informed care lens. So we should approach all of our clients as if they have experienced a trauma. And I usually try to, sorry.
I was going to say, Carly, there's a question in the chat that I think is really like needing to stress.
Oh, sorry, I can't see it. So, okay.
No, that's no problem. So asking, is it possible for a person not know they have a brain injury? Like it happened as a child and then now having issues as an adult, and that is very possible. So that's kind of what Carly's been talking about. And we see it all the time, particularly because children bounce back physically really, really well. So childhood brain injuries, they tend to not be as noticed, not you know, those pieces. And so the kids bounce back physically and it's seen as, hey, everything's fine, everything's great. But what then happens, and what we now know, is kids tend to age into their injury. Which means we're not asking 8-year-olds to do complex adult tasks because they're only 8. So if a kid has an injury at 8, you can't really assess how well they're doing because they were just 8 at the time. But then what happens is as they get older, they start to really struggle and those problems show up. So similar to like people not getting adequate care and treatment, a lot of the individuals within the populations that we're all working with have had, you know, like childhood domestic assault, fighting, those type of things that maybe they didn't even get adequate treatment at the time and it wasn't documented that they had a brain injury or they were even told that. So just really wanting to stress that's part of why, as Carly said, you can't just ask that question if you ever had a brain injury, because people they may not know. That is really just the tip of the iceberg of actual injuries, are those that self-identify and say, yes, I've had a brain injury. So I think that's really important to stress as far as moving forward with this. And then the only other really quick question in the chat was stuttering linked to brain injury. And yes, that's really common. We do have individuals that stutter after brain injury. We refer a lot of individuals with brain injury to speech therapy as part of that speech. So people might have a stutter. People develop slurred speech sometimes. We have people that develop what's called aphasia, so the kind of word finding problems. All of that is part of possible after brain injury. So sorry to interrupt. Now you can go back to trauma-informed care.
Yeah, I don't know. Teams, I can't see the chat. I can see you, but I can't see the chat. So
Yeah.
I don't want to mess with it because I'm going to goof it up. But yes, very good questions. And yes, very important to note. Okay, so when we're doing a screener, we want to approach all clients like they've experienced trauma in their lives, and preface with this screening could trigger you. I almost always have Kleenex somewhere in the room where we're doing it just in case. But really, I don't need details. And that's hard for a lot of people. I'm sure the clients you work with, they like to kind of some undershare, I guess, but a lot tend to overshare. But I don't need a lot of the details. I just need simple yes, no answers to this, because we really don't want to trigger people. That is some of the pushback we've gotten from like our domestic violence shelters is, you know, this is a triggering. We don't want people to relive their injuries, and we don't either. We don't want to trigger anyone either. We want them to know though, so that they can get the appropriate supports in place. So again, we just keep talking about, you know, you don't have to share anything you're uncomfortable sharing. And then, you know, talk about what will happen next. So again, that whole routine piece is helpful for brain injuries. So when they know what's coming next, that can reduce a lot of their anxiety. So we usually say, okay, so we're going to do this screening with you. If you do screen positive, then we can talk about a symptom inventory and some referrals to maybe make about how to help you manage this brain injury throughout your life, but just kind of give them an idea of what to expect throughout your encounter with them for that day anyway. And we have all of this built into a portal in our website, on our website. So there's the process is written out, there's a consent form, there's all these things. And so we're doing this a little more generally today because there's so many of you on here and we don't know who will decide to screen or how this will work. But we're not going to give you access to this portal. So that it's username and password protected until you have a conversation with us. So we're happy to give you that information eventually, and your agency or you personally as a support staff at an agency is welcome to screen. But we would want to have a conversation first about, just really make sure you understand the protocols before we unleash it all. So this is all available, but again, today we're not going to give out the username and the password, but this is a pretty user friendly. You can just click here on data entry portal and submit your data that way or your information that way, or you can do it all on paper. And this would be like the links to it all on paper. Eventually, we need to see it all in this data entry portal, but whatever way you initially decide to collect is up to you. So some agencies might have, the actual social worker or care coordinator type person interview and do it on paper, and then they might give that to an administrator, secretary type role to input into the system. But I find it easier to just do it right in the portal from the beginning so that you don't have paper and pencil, but and then have to do the transferring. But whichever way works for you, we tried to be cognizant of the different types of learners and agencies, and this does work really well on your phone too. It does translate pretty nicely to a small device or a laptop again, or you can bring printed versions. We developed this flyer, and actually, I don't know if Rebecca, you saw it, another state stole it recently too, which was cool to see. But Rebecca developed this after she would do screenings down at Southeast and Fargo, and she would screen, and she got a lot of questions from individuals that attended those groups, like, why are we doing this? Wouldn't I know? Who cares? What's the benefit of this? Wouldn't I know? What does it mean? Does it change who I am? So she basically put all this into a document, and we go over this together with clients that we're screening one-on-one, just so they know why. And I usually explain this one when I go to the deck. It's one of my first things I say at the Downtown Engagement Center. I'll say, okay, 12% of the general population have a brain injury. But when we look at special populations, like you guys here at the deck, those numbers are much higher. So we are here to see if, possibly why you might have ended up in this situation is due to a brain injury. And so just kind of basically explain all of that. And then kind of the next steps as well. So I usually have them, we go over it together, but we also have them take that home to kind of review later or show spouses or anyone that they are close with. And then here's the actual screener. So this is what it looks like on paper. Again, it is TBIID. Oh, it says and other acquired. That's why I was confused when I was saying this stuff earlier. But so yeah, number one is looking at loss of consciousness. So we read in black. What's in black is the whole prompt that you read. So, you read it nice and slow for them at their level. We want them to think about injuries you've had in your entire life, especially those that affected your head or neck. It might help to remember times you went to the hospital or emergency department. Think about injuries you may have received from a car or a motorcycle wreck, a bicycle crash, being hit by something, falling down, being hit by someone, playing sports, or an injury during military service. So that right there, that whole long statement is basically trying to trigger those memories of all those different instances that they may have had throughout their lifetime. So then we ask, were you ever knocked out or did you lose consciousness? If so, then how long were you knocked out for? Because remember that severity continuum. So if they were knocked out, that mild, moderate, severe basically is how those are laid out there. And then we want to know how old you were the first time you were knocked out or lost consciousness. So we don't need to know details. Again, it's very basic. Yes, no, I don't need to know who caused it or what caused it. Really, any details. All I need to know is the loss of consciousness and how old. And there's a lot of research that shows if your injury happened before the age of 15, that you are more likely to be involved in a cycle of failure. So homeless, substance abuse, criminal justice involved, that type of thing. Number 2 is looking at a period of time in which you had multiple repeated impacts to your head. For example, playing sports, serving in the military, or a history of abuse. I've also seen things like, I have a BMX rider that I think he's at like 25 concussions in his BMX career. So, you know, it can be not even contact sports necessarily, but just more sports type injuries. But we basically want to know, when did those injuries start? So like this guy started, I think, racing when he was like 8, and he stopped when he was like 30. So that's a significant amount of time for your head to get impacts. Number 3 is looking at a loss of consciousness from drug overdoses or being choked or strangled. So I see both of these quite a bit more than I would ever like to. I do see a lot more of the overdoses than I do the chokes and strangulations. And I would say those that have had multiple overdoses that definitely have that, they score much higher on a symptom inventory than someone that maybe had only one, but still it's significant. We don't want people overdosing. And then the very last one, it's important to stress, have you ever been told by a doctor or other health professional that you had any of the following? A lot of people go on WebMD and self-diagnose and do all those kinds of things, or they, you know, they might confuse like a drunken blackout with a seizure or something, or think that they have like a gap in time, but it really needs to be a doctor that told you. And then we would check those boxes as well. So those were all those kinds of things we talked about at the beginning, right? For those acquired brain injuries. And they really get at that loss of oxygen piece. You'll notice, you can see that in several, and they're just really honing in on that, because I think a lot of people forget. It's surprising how many near drownings you hear about too, I guess. I didn't realize that before this role. But yeah, so this is the screener. Like I said, it takes about 5 to 10 minutes to implement. And then if someone screens positive, well, let's talk about negative screens first. So there are people that you're probably maybe thinking in your head, oh, I bet they have brain injury, but then you're going to go and screen them and they're going to screen negative. But that doesn't mean that there isn't something going on, right? So there's possible other explanations. It could be a medical or environmental. So some of the medical things that we see that often look like a brain injury are developmental disabilities. So those would be kind of more those at birth type injuries. HIV, especially when it's untreated, can look like a brain injury. Substance use, serious mental illness, medical interventions, or being in an ICU. So having to be like on a ventilator isn't good for anybody. We aren't meant to be artificially kept alive like that. So there's a lot of kind of lingering effects that can happen after that. And then other kind of chronic conditions sometimes can look like brain injury. Environmental factors we tend to see: unstable, unsafe or inadequate housing, poor nutrition or lack of access to good food, sleep deprivation, huge. We basically, I think it's like if you haven't slept good in 3 nights, you basically are intoxicated throughout your day. Like it's in the same level as someone that has like abused alcohol. Sleep deprivation is extremely taxing on the body. Trauma, stress, and a low literacy rate. All of those things can look like a brain injury, but aren't necessarily a brain injury. And if you're struggling to kind of figure that out, we can try to help. Being I have a background in special ed, I have, you know, and Rebecca and Nikki, we've all been doing this for a very long time. So we tend to we can give you our opinions on what might be going on. But if they screen positive, now we want to see what's bothering this person. So we want to give them that symptom inventory. And so I'm going to skip over that. Okay, so symptom inventory. This was developed out of Colorado, a place called MindSource. So there's a brain injury something in every state in this. Dr. Kim Gorgans, and she's a neuropsychologist. And she also is a professor at Denver. And so she took a bunch of neuropsych students and they worked on this. And this is intended to be a placeholder for a full neuropsychological battery. So I don't know if any of you have ever had a client that you've needed to refer for a neuropsych, or if you've had one yourself. but it can be tricky to get in. First, the route is usually you start with your primary care provider, and then they usually have to make a referral because they want to rule out any other medical reasons, like we were just talking about on that other screen page, of to why you might be doing what you're doing, or the client might be. And then they send them to the neuropsych. But here in North Dakota, we're very limited on neuropsychs. You usually need insurance. You have to remember the appointment that was scheduled for, months out, usually. Lots of different factors of why neuropsychological full battery testing is hard. And so this is awesome because this serves as a placeholder and can just kind of give us a broad idea of where is this individual struggling the most. And so we don't tell them till they're all done what each section is looking at. But, one can infer that like section 5 is looking at like physical, sensory, motor, right? And so we go through all these sections, and the last section is looking at like emotional dysregulation. But you can look at some of these questions and see if any of your clients sound like people that might struggle in these areas. This is all self-report. Shannon got to do her first one yesterday at the Downtown Engagement Center, and I will admit it was pretty painful. When you do them with people, it can take a long time to do the symptom inventory. He really like thought about every single one, and he was like really overanalyzing it, to be honest. And so it can be hard. This one can take time, and I'm not gonna lie about that. I would say if you're gonna do a full like screening and symptom inventory, it can take about an hour, but we don't want that to deter you from not screening. So even if you just want to screen and you don't have time for the inventory, you can have us do the inventory, or you can send it home with the client and have them bring it back. There's options that you have here if you feel like this is too much of a time suck for you, but it really is going to help the person a lot. But basically, we want to know, do you have this problem? And if you do, how much does it bother you? And then what happens is we look at how they score. So if they scored high, let's say in the area of speech language, then we would provide them with a tip sheet that matches with the area they scored high in. So the individual we assessed yesterday, I want to say he scored high in like 4 or 5 areas. So he was given 4 to 5 tip sheets, which is a lot, but ideally he will take that to his care coordinator. That's what he was coached to do, and work through each of them together, more on a month by month basis or week by week, rather than wham, here they all are. But here's some of the accommodations we would recommend to help work on speech language. We also have tip sheets that are written for the perspective of the professional working with the individual. So they're just written in a different way. Sorry, I thought I had an example of one, but I don't. But honestly, they look the same. They have the same image. They look the same. It'll just say for professionals across the top. So like yesterday when we screened that gentleman and he screened positive, and then we did the symptom inventory and then gave him his tip sheets. Now he was also given tip sheets for the professional, and he does work with his Community Connect. And so when he sees his Community Connect provider on Friday, was directed to bring those tip sheets to her so that she knows he has brain injury or potentially has brain injury, and some strategies that might help her work with him. And then his responsibility is to kind of review these ones and go over them. But they are going to need some support doing that. And we recognize that at NVBIN, that we can't just hand someone a piece of paper and expect them to figure it all out. There is recorded videos of me doing going over the tip sheet with people, talking to myself. It's just me in the video. But if you wanted to, have a client go into another room and hop them on a computer and push play on that YouTube of me doing it with them, that would be another way to meet this kind of goal of how to explain accommodations for speech language for them. And then we could help set you up with what speech language practitioner would make the most sense to see. And not everyone that scores high in speech language is going to need to go to see a speech therapist, but we would look at that kind of by how high they scored, and just the different things that they have access to, like insurance and telehealth and those kinds of things. But here is a list of all the tip sheets that we have available. So you'll see this list is more than 9, right? Because that symptom inventory covers the 9 most common symptoms after brain injury. But then there are a lot of people, or a lot of other side effects like fatigue that pretty much everybody with brain injury has some level of fatigue after. And anger is another one that almost all of them have anger. It's kind of this last right-hand side here. These from accommodations down, those are ones that we give everybody. And then these 9 here from memory to emotional dysregulation are the ones that are scored and given by how they actually score on the symptom inventory. Yeah, the tip sheets are helpful, and I think eventually at IndieBin we will have also some more guidance around them, you know, maybe like a worksheet, even like I'm going to work on this tip sheet this month, and I'm going to work on this accommodation, and really try to lay it out more for them. And that's what I've been kind of coaching like the care coordinators that I work with through that piece right now, just structuring it for each person, but hopefully we'll have some of that rolled out soon at IndieBin for you guys too. And yeah, we recognize that the tip sheets aren't enough. And so really what I think is beneficial after someone is told they have a brain injury or screens positive is further education on it. So this is the class that we offer. This is an old flyer here you're looking at, but there is one available on our website right now that will be held at Mountain Brook coming up here soon. That's a mental health recovery center in Grand Forks. We will be doing Living Life Fully, but this can be offered in your community as well. So we lead the classes. This one here you're seeing was for a virtual, so it does translate nicely to virtual, or we can do them in person. But it is a 7-week series that was developed out of Colorado. Again, Colorado really has a lot of nice money to play with. If you get a DUI in the state of Colorado, the money goes into a fund that supports brain injury research and all that. And so they wrote this, they call it the AHEAD in Colorado. So it's called Achieving Healing Through Education and Determination. And we just thought that was kind of a mouthful. And so changed it to Living Life Fully After Brain Injury, or we call it like LLF sometimes for short. But basically a 7-week series that addresses a lot of these things that individuals with brain injury are struggling with. So the first week we talk about understanding brain injury and symptom recognition. So everyone that takes Living Life Fully takes a symptom inventory as part of the class too, but ideally they would maybe already have one done and then we could use the results. But if they need one done before class, I will complete that with them. Because in session 2, we're going to talk about memory, but we're also going to learn how to set some goals based on that symptom inventory and how you've scored on it. Session 3, we talk about a little emotional regulation and how to kind of determine coping strategies. Session 4 is communication. So that's not necessarily like communication like how we speak, but communication with others. So like, what kind of a communicator are you? Are you passive aggressive? Are you aggressive? Are you assertive? You know, and what's the best way to be? So we do a lot of role playing with that. Section 9 is all about anger, because anger is a very, very common response. No matter how the injury occurred, many people are mad about it and they want to know what to do about it with that anger. Session 6 is all about like emotional dysregulation and kind of like stopping and thinking, and we write like a mock behavior plan. And then the last session it was called, from the AHEAD, it's called Grieving and Brain Injury, and we changed it to Finding Your New Normal because we thought the grieving was just a little negative and kind of scary. You do need to grieve your old self and kind of find your new self, but we want to focus more on that, finding that new normal and being positive about that. So we can throw links in the chat for the one coming up, but again, this would be something you could bring to your community as well. Oh, and I forgot to delete my note to insert the flyer. I just did that like 5 minutes ago before this started. So Brain Injury Lunch and Learn is something that we offer weekly right now in Fargo, but I would love to see it brought other places. So what happened was I was offering this one, Living Life Fully, at the deck. But Living Life Fully really builds on each other, and you don't need to attend every single session, but that is best practice, would be to come to all 7 sessions. Well, as I'm sure some of you know that have maybe worked with the homeless, that consistency routine piece isn't always there. They weren't coming to every session. They were coming, but not to every one. So they were missing kind of critical sessions. So I kind of revamped it, and I basically changed it to lunch and learn. So they come every Monday. We bring in lunch. We order it from Hornbachers and we bring it in. We actually won a grant from NDAD that has helping to fund this for a year. So we bring in the meals. And like yesterday was tater tot hot dish, green beans and a roll. So pretty good meal, not too shabby. And they eat to entice them as well, because obviously, but also because we don't learn when we're hungry. So that was another thing that when I was first started teaching the classes, we weren't offering a meal. And a lot of the people were very, very checked out and not engaged. And we don't learn when we're hungry. That's kind of a basic teaching thing we learn in school. And so I thought, well, let's try to feed them while they're learning. So we call it lunch and learn, just like what you're at right now. But basically, yeah, we give the free meal and free resources. And I start every living life or every lunch and learn with the screener. We don't have them actually fill it out, but we just have a conversation about it. About the first 5 to 10 minutes, I say, you know, these are the ways you can sustain a brain injury. You don't have to share it today if you don't want to, but we talk about that. And then I show them a list of topics. So we have a list of topics, you know, basically a lot of them are taken from this class. So like communication or anger or stopping and thinking, but it's not in such a progressive order. And there's many other topics that we give them. So they have their menu that they select the topic from. And when they pick the topic they want to talk about, then we talk about that for the day. Last week was, or this week, yesterday was interesting. We had a gentleman show up, very inebriated, I will say. He was feeling no pain and having a great day, but definitely impaired. And he reported that he had relapsed, and it was very obvious to everyone that he had, but he said, let's talk about it. And so we did. We talked about substance use after brain injury. And it was a good, you know, it's good for them to know basically the correlation. So about 20% of people develop a substance abuse habit after brain injury, and a lot of it's due to that impulsivity piece. So we talked a lot about that, and just why like a lot of things like AA don't always work, and how like things more like the harm reduction model are better for this clientele, and things like that. And I try to give good strategies. We usually have a handout that they can take with them on the topic that we talked about that week. We have our resources available, like our memory notebooks that we'll give out. We have our playing cards. We have the tip sheets that we have them available to go. So they're in like a little small version instead of a full printed sheet. It's on a carabiner with ND Bin's logo and everything. So lots of good resources for them to take away. And I do think we've been doing this, I think we're coming up on about 2 years of either a combination between Living Life Fully and Lunch and Learn at the deck. And I do think it is making a difference. I think we're helping people learn more about like Community Connect and Free Through Recovery, and get those care coordinators to help them get all their ducks in a row, basically, and just connected to the right resources. And then usually I coach them to make sure that their care coordinator knows about us in turn, and when we can all kind of come together and be a team and work for full circle. So so that's kind of what we're offering for screening. And if you would like to start implementing any of the things that we talked about, we would love to have a conversation about that. So your agency could definitely start screening. You could offer Living Life Fully. Really all ND Bin needs is space, a space to house it. You can do Lunch and Learn too. Lunch and Learn might get a little bit trickier with having to figure out budgeting for that. That was why we had to apply for that grant for ND80, because our grants don't let us buy food with the funding. And so we had to get creative with that, but we can try to get creative. Or if like for example, the mission here in Grand Forks already serves a lunch meal. So I'm hoping that to start offering Lunch and Learn at the Grand Forks Mission, and just basically I'll be in a separate room and, you know, grab your lunch and come see Carly if you want. So if that's somewhere, an option, or Living Life Fully, like I said, Mountain Brook is offering it. So they just house the space and we show up and bring all the materials and we teach it and all that. But yeah, so your next steps would just be to reach out to me and say, hey, let's do it. So that is all of our
Awesome.
information. Any questions?
Looks like Roberta has a plus minus and a bunch of nines. So it could be a cat. It could be a cat. I'm going to guess it's a cat. that did
Yes,
that.
or a small child, yes.
Or a small child. I just go with the cat since you mentioned a cat earlier too. Because we do see that a lot. A lot of people's animals, that's their number one concern. I've fostered cats and dogs before many times for people going to treatment and
Sure.
prison. So you guys,
Yep.
I'm going to put in a link here in the chat, and this time it does work because I tested it. So it does work this time. And oh, Laura, your dog is sweet. So go ahead and fill this out. And it's going to be just like a survey. And then after the survey, if you need attendance or CEU, it'll link you to that as well. The survey, of course, is anonymous though, just so that you know. And then if anyone wants the PowerPoints, I'll send last week and this week. I probably might have to do them separate though, just because it might be too large of files. Just put your email in the chat. When we don't register, it doesn't give me email addresses in the attendance report, just your names. So therefore I don't have anyone's emails. So that was something that I learned as well.
Yes. Well, and I
from
saw
last
somebody,
week.
I'm just trying to look through the chat to make sure I didn't miss anyone. Someone asked about, is the inventory sheets available? We would want to have a conversation about implementation of that, but yes, you could totally do that.
I put the link for the sheets just that are on our website in the chat. So the sheets are just the general information they are on our website. I put that link in there. But as Carly said, the inventory sheets, they do match up with that symptom inventory. So the tip sheets that are just the basic symptom information, those are I put that in the chat. But they do match up with the symptom inventory, which is a chance to kind of get that information from, your client and really figure out what their issues are and what they're struggling with on a day-to-day basis, and then correspond that to a tip sheet. I see that there was somebody with their hand raised.
There's a few people, so yes.
And I will say, so next week, we are going more in detail of my client screen positive now what, where we will be discussing much more of actual symptomology and ways of supporting people and going into more detail than just the tip sheet. So, but I'm also more than happy to answer any questions.
I have a quick question. It's Jen. So with the backlog of Community Connect applications, are there any keywords or things that you can recommend us putting in for applicants who do have brain injuries that will help them rise to the top of the pile?
Not really. I mean, it's prioritization. So I just recommend helping the person answer the questions to the best of their knowledge, to the best of their ability.
Okay, thank you.
So yeah, I apologize. I wish I had a better answer.
I would agree with Kelly. Neither Kelly or I are really, that's a process. And so I don't have a clue on to. I would just really always encourage people. And what I've found with people is when people are answering things like that or documenting their struggles that they're dealing with, people always want to err on the side of putting their best foot forward. And so oftentimes individuals will downplay their symptomology or what they're dealing with. And so I think, obviously there are those outliers that, whatever, but for the most part, what I have found is clients want to hide how much of a struggle they are having, how much of a day-to-day struggle, things like reading, filling out applications, forms, making appointments, things like that are. And so you really want to help that client, one, come to a self-acceptance on what they're really dealing with, but then also fully document that as part of that application so that they really are, it is being shown how much of they are struggling, because then that is what is going to help with that preferential treat, that selection process.
Yeah, even in the training I did this morning, one of their pre-test questions and post-test is individuals with brain injury tend to blank their deficits, and it's underestimate. They always underestimate themselves. They're really good at saving face and smiling and nodding and everything's okay. But then when you start to ask questions and try to get more information, you're like, oh no, that's not the case. So keep that in mind. Even if you do end up doing symptom inventory and someone's, kind of between two, I usually go with the higher one because they tend to underestimate their own abilities. So yeah.
We do have
Yeah,
a couple.
I always try to answer those questions, have them answer them from on your worst day, what is your experience, not your best day.
Yes, exactly. That's a good
pointer,
Jen.
Yeah, I would like to my name is Marco, and Kelly, I'm not getting anything in the chat for them.
Oh, you're not? Okay.
I haven't seen anything. I've been trying to check.
What's your email address?
Hold on. I'll tell you right now.
How about the next person that had a question while we're waiting on that?
mpolo215@outlook.com.
215?
Yeah, mpolo.215@outlook.com.
I'll email you.
Thank you.
Okay, and then we had Niam had a question too. I don't know if they're still on here. They may have popped off. Okay. Does anyone else have any questions or concerns? If you have a question about last week, just email me. I put my email in the chat. It's kellarson@nd.gov. If you have a question about it from last week. And then Stephen, I don't give you a CEU. You have to fill out that survey. So I don't send anything with CEUs. I don't email them. Okay, Niam's question was answered. Good.
Tiffany had a question. Tiffany Scott had a question about how can she get screened? Feel free to give us a call.
Yeah.
That is definitely anybody, we have our toll-free number. Anybody is welcome to just kind of call at any time. We do have on our website, our toll-free number. We also do have a referral form, all of that. But, feel free. What's the number? You would want me to have that off the top of my head, Tiffany. Out there,
855-866-1884.
Okay.
Yeah.
I put it in the chat for you too. Nikki answers that number though. She might not be able to do it right the second you call, but you could say, can I set up a time to do a screening? That was interesting that you asked that, Tiffany, because at the Downtown Engagement Center yesterday, we were visiting with Jan Eliason, who runs the deck, and she was saying that she feels like we need to do another screening training because when we did do screening training with the deck, there were so many of their own staff that screened positive that it kind of came more about the staff than about themselves or about their guests that come to the deck. So there probably are a lot of you with brain injury too that could benefit from, these accommodations too. This is a diagnosis and to help the person to get resources. So it's not a diagnosis, Jamie, but it is we could help set up the right steps to get them a diagnosis if that's something they wanted to pursue. But this is basically just saying that something's up here. We need to look into this further.
I thought I placed the survey link in the chat.
And another thing that I will say, Jamie, along that, getting the resources, one of the things that we find with brain injury is often when I was doing screening at Southeast, I had a group, you have people that they already have a lot of diagnoses. that are getting them access to Community Connect, Free Through Recovery, whatever, case management services, but things aren't going well. They're still struggling. There's kind of a glitch there as to why it's not successful. And so oftentimes getting the brain injury information and just even that screening enough to look at it from a different angle can help all of the other pieces come together and sort of shines a light on, oh, okay, this is why, this client is not successful with how I'm approaching them. This is why they've been struggling with this. Let's do it from a different angle now that we know about this brain injury. So that's part of why we want this information for you, is that really it's ideally to help you kind of know more about these clients you're working with and potentially say, okay, this is how I can work better with them. So, and with that, that's kind of what we'll talk about next week as far as that, like how to actually like adjust how you work with individuals.
Those are good questions.
Well, thank you, everybody. We really appreciate it.